All right, everybody. It's Doc V from EMDR News coming to you 9:30-ish. Most weekdays, sometimes my Fridays get assumed, so I don't come in live. But I am looking to have a recorded version for you when I do come in on those Fridays. So, or when I'm not here on those Fridays. So just keep that in mind that we should have something for you every time that you come and visit us. Okay. So welcome back to EMDR News, where we have uh, where we explore signal over noise. We are going to be exploring pain a little bit today, some thoughts and concepts around illness and injury, and how they affect our clients and their recovery from their main complaints, their difficulties. I'm excited to be here as always, and this is a subject that I love talking about. Um, it seems that any subject that I bring up is a subject that I love to talk about. So I do want you to hang on to the end today because I do want to talk about some of the tools that I'm putting together, and I think that they will make your life a lot easier. And I believe that the sooner I can get them to you, the sooner that your ability to work with your clients can be slightly improved. Right? Just always trying to figure out how to improve our clinicians' ability to do the work that they need to do, the good work that they do, and what they bring to their clients. All right. So if you, throughout the process, if you do want to leave a comment or ask a question, feel free to do so. I think that I'll be able to pick it up here. I got most of the places locked in, so we should be pretty good to go. And then we might even share it online if that makes sense. So we can actually have the stuff, the actual comments, show up on the screen here as well. So hopefully we can get all that done for you. It should be interesting. I'm excited. It was kind of exploring the upcoming Imagery conference in 2 weeks. It should be a really good time. I've already been speaking with a bunch of colleagues in regards to what's going to happen there, and it's really we're all pretty excited about it. I got like 3 dinners planned. I'm hoping that, you are able to connect with people that you know and are happy to see, and you could have some dinners, some time with them too, in the evenings when you're there. So it should be pretty good. And again, if you get there early, if you bring in your families, Disneyland is right there, right? Anaheim, California, it's right around the block. If you do want to go to the beach is there too. However, it's a little bit further away. Not long, but it's not next door. Like Disneyland is like almost next door. So think about it. It's something worth exploring in terms of being able to, not only go and get your CEUs and get the current events in EMDR, but also collaborate with other people, have some time away, maybe make some save states, some resources that you can tap into later on, right? So it should be pretty good. Okay. Just looking around. Okay, so we also have the ISTSS thing, the that conference coming up, and that'll be in September in San Antonio. And I've already addressed how much I love San Antonio. I've went there when I was in the Army for a bunch of times because it's the center, it's the AMED Center of School, the Army Medical Command Center and School is there. That's where it's located. So my basic training was in Fort Leonard Wood, Missouri. Lost in the woods, Missouri, as they like to say. And then my medical training was in Fort Sam. So we would go there for your medical training, and then also any other training that you're going to do having to do with medical stuff usually ends up there. My last time there was last year, and I went down there for traumatic event management facilitator work. Well, this is all military stuff. So, but yeah, I went down there for the traumatic event management facilitator course that the military is putting on for us there. It was good. I got back to the Riverwalk. I don't know if you've ever been there, but it's fantastic. It's awesome. It's like a little canal that runs right through San Antonio, and on either side there's like restaurants. You know, you can take a boat that goes down the little canal that can be fun. On one end, there's a mall, and I don't even know what's on the other end. I haven't walked that far. But you can also see the Alamo in that area. The Alamo, like you look across the street when you're there, and the Alamo is like right in front of skyscrapers. You know, this little tiny mission style, once a church thing, is anachronous. It's out of place. It's it's pretty kind of cool to kind of walk through it and learn the history of what happened there. But at the same time, it's just weird being in this little tiny block bubble of history surrounded by a city. All right. But it's great. I don't know if you've been there, but it's great, and I would definitely advise if you can go to go. Right, it's fantastic. Okay, so let's get into it without further ado. So today we're going to be talking about chronic pain, injury, and illness. Now, um, with acute injury, with acute aspects of illness and so there's not much we can do about it. When we're talking about flesh wounds, there's not much we can do about it. Doesn't mean there's nothing we can do about it, but the actual physical pain that comes from the actual physical aspects of an injury or illness, that might be less approachable, less amenable, but there to EMDR treatment. But there is a lot of research out there from at least 2014, 2013, going through. There's a systematic review on using chronic pain, using EMDR with chronic pain, with varying success. Right. So just because there's research out there doesn't mean like, hey, there's research on it. Right. Well, what did the research say? So the research is kind of all over the place. Right. You know, it says, okay, yes, it does work. It can show some demonstrated gains that last even up to 6 months. Right. So it has some success in chronic pain. But then you look at how big was the study and all of this stuff, and there's some generalizable issues, generalizability issues, and then there's also some issues in terms of what pain are we looking at. There's some specific studies that have to do with chronic back pain, and again, with that, it does demonstrate there's a relief for at least 6 months, right? You know, when they check again, about 6 months, they checked again, and the relief was still there for many of them. And then it did work on IBS. They've done work on my goodness, I don't want to get it wrong, but so let me just use the common acronym of PMS. But they did work on the discomfort that comes from that. So there's a lot of work out there. One of the people that I first was introduced to, not literally, but through his work, was Mark Grant, and he does a lot of good work on chronic pain and pain, and he has a pain protocol. Mark Grant is he has a website, and you can go to the website, and it's got a lot of information free on his website. But he also has a book on using EMDR with pain, and you can find a lot of different ways of using it there. Right, using how you can use the protocol he has for chronic pain. So what I was saying before with like you can't really get to the physical pain aspect of things. What we can do is get to all of the memories, right? Because that's what we do with EMDR, memories that surround the pain, right? And there's a lot of them. And when we think about what we could do before, the different roles that we had, that because of this pain, this chronic pain, we can't do anymore. That's something that will improve, rather not improve, will make the pain worse, right? The pain can be experienced or perceived as worse because we are now having these layers of emotional distress on top of it. So it's pretty. It can be pretty difficult for people to accept life changes, right? And everybody's a little bit different, and different injury or illness can cause the issue in different ways. But still, the end result is that people will still experience the pain more intensely sometimes because of these memories and these thoughts. And it's not just the memories and thoughts about roles that were lost, about things that they couldn't do. Like I have a client recently was talking about his motorbike, right? He just sold it because he's got such bad Again, I was trying to make sure I don't get too deep into specifics. But he has such a bad pain. I'm not going to go into what kind or anything. That riding the bike is painful. And what does that mean? That means that he can't go and ride with the people that he used to ride with. He used to have a group of people that he would go and ride with. So what happens, right? He doesn't have that group of friends anymore. So now he's isolating, right? So that's another additional layer of stuff. And if you isolate, if you don't do stuff, chances are you're going to continue to not do stuff, right? So you start to pull back from other activity as well as time moves on. So that's just one example, right? Having to sell something that you like to do because you're no longer able to do it. Also, I remember that was a motorcycle, but I remember somebody that was on a bicycle, right? That would bike all the time and everywhere until he was hit by a car. And because he was hit by a car, he had, injuries, and these injuries caused pain, and the pain it isn't going away, right? There's some pain there that is going to stay. So he still wants to ride his bike, but now he's deathly afraid of riding his bike. So that fear can also have an impact on the perception of pain, because when you're thinking about going on that bike, right? When you start getting on that bike or see other cars, stuff like that, when things get triggered, can trigger the actual physical pain. It can trigger their memory of that, it can tense you up, and all that tension and everything that happens can increase the sensation of the pain. Uh, and then same thing here with this person. There was other things that he did which were active, and with certain friends groups, and now he has to just watch them as they do these things because he can't participate because of the pain, right? So that's just two examples of how pain can change your life. And within the context of changing your life, these are now memories of, when I came up to this conclusion, when I went to do something with this group and I was left to the side while they went and did it. I could watch from the sidelines, right? All of these things can start layering on other memories that we would have to work on within the context of EMDR. And then we can, right? We can do that work. And that's what we really need to get to and really want to get to, is try to figure out, okay, well, what are the memories that are sitting here supporting the exacerbation of the perception of pain? Um, So when we think about chronic or actual pain, there has been some research, or some success, maybe more anecdotal than there is supported by research, but that the BLS itself can help bring down some of the physical experience of pain, even without working on the memories. But right now, I just want to focus on working on the memories, right? Because that's the biggest piece here. What do you work on, right? You do work on the trauma, right? The car accident, um, whatever it is that caused you not to be able to do that thing. So the accident on the bike where the person was hit by the car, right? We would work on that because that's pretty serious. And we did, and that was successful. And then we work on other memories when we move forward. But that's not what, when we do EMDR, we don't always just start with the trauma. We, we want to get the map, right? We want to get an idea um, of the whole space, what's happening in this space, right? So what I mean by that is, even though we're going to probably start in some cases in a different place than the touchstone memory, even though we're going to say, hey, we're going to work directly on the criterion event or whatever, we still want the map, because if there are feeder memories or blocking beliefs that are coming up, we want to have an idea of what they are before they start getting in the way, so that we can better try to maneuver the client through their memory network and get to the appropriate places so that they can have the best results, and depending on the time you have, right? And that's what I'm in the context of the shortest amount of time, right? Because when I'm thinking about this stuff right now, I'm thinking about people that have 10, 12, maybe 15, maybe up to 20 if they're lucky, uh, sessions to do a treatment episode because they're in a community-based organization, or they're working for the Veterans Affairs Administration or something like that, where they like treatment episodes. And just by the way, the VA, you're not stuck in that treatment episode, right? If you're still in need, they can have case conferences and talk about your case, and they don't have to stick to that 20 sessions all the time. It's just the marker, right? Like this is what we're saying. This is the goal, and then everybody's case is a little bit different. So we can work on the memory of the incident, and then we can work on these incidents where we recognize that our roles are no longer, we're not able to stick with them, right? Those things that we used to enjoy, we can't do them. We have to come and find other things that we might be able to enjoy that don't exacerbate our injuries. Okay, so that's just the chronic pain aspect of things. So it does work. There's research that shows it works, and Mark Grant is a fantastic resource. So you can go look up his work and the pain protocol that he has. Now, if we work on illness, this is a whole bunch of layers, right? Um, so sorry, I had to when I think of illness, it's a little close to me right now, so I kind of just had a little one of those little dives, right? Like, oh, illness. So illness is a pretty serious one because depending on what the illness is, there's no way out of it. It's not just, something's broken, I can't do it. It's, this is this could be, the rest of my life. If it's terminal, for example, what does that mean to people, right? What does it mean to have a terminal illness that you now more than anyone else in history or in life or whatever, everybody's like, oh, you can die at any time. You walk out on the street and you get hit by a car. But well, I got 5 years, so I could get hit by a car. But if not, I got 5 years, and that 5 years is not, a steady 5 years, right? Because you're going to go through treatments and stuff like that. If we're talking about a terminal illness, and so it's a bumpy 5 years, right? So all of that is a huge piece. So we can look at a client that has multiple illnesses, right? So I'm thinking about one right now while I'm saying this. So this is actual stuff. I'm gonna again try to or do. I'm not gonna try. I'm going to do. Not bring up some identifying stuff. But this person, they ended up with diabetes 1, right? And diabetes 1 isn't as often seen even in medical facilities. It's diabetes 2, that people usually see. So they ended up with diabetes 1, which is a layer there. And then their significant other had a problem with that, right? Because they didn't sign up for a sick significant other, so that was an issue, right? So that relationship became tense and uncomfortable and eventually was dissolved. So even illness like that can have an impact not just on you, but on your relationships. And for those that don't know about diabetes, diabetes can have you end up with an altered level of consciousness. So because of sugar issues and some of those things that come up. You could, like being drunk sometimes, that's what it looks like, or, something like that. You don't really have as much control over things because you have an altered level of consciousness. And so if you have diabetes like that and something happens with your sugar, and now you have an level of consciousness, you're in the position where things could happen socially. You could lash out at people that you're close to. You can do crazy things that are uncomfortable for other people as well as yourself. You can get yourself into precarious circumstances and situations. And some of the things that you say when you're in this altered level of consciousness can be hurtful to other people and again damage relationships. So relationships throughout the process of illness is always going to be something that could be affected, and we can think about diabetes as a big one there, but you can think about other things as well. When we the, Virginia Woolf has I think it's On Being Ill, but she has a writing on on being ill, what it's like to be ill, and she talks about the way people treat you. Right? People don't know what to say. People when they come in, they say the wrong things sometimes, but they don't know what to say if you're ill and seriously ill. Right? And that whole process creates more and more present triggers, creates these weird moments where things are uh, uncomfortable between you and the people that you work with or live with, or, people you have relationships with. So let's go back to this diabetes piece, right? So you could have diabetes and it might not end there, right? You could end up with other issues as well. If you think about the adult and childhood experience scale, the ACE scale, right? The ACE scale, if you remember, if you know, is a scale that you can go into that talks about your childhood and gives you a higher score on the ACE score is probably correlated to higher levels of mental health illness and issues, but also physical health issues and illnesses, right? So there is some demonstrated evidence that says, hey, trauma can actually lead to physical injury and illness as well. So with that in mind, now we have somebody that maybe had a child history that was abuse, ended up with diabetes, and now maybe they end up with another like a disease like cancer or something like that. So that's what happened with this one client, right? That they ended up with cancer as well, and that process was difficult. Um, the things that happened within the context of getting cancer on top of diabetes it made things even worse, made them feel like they're not even safe, right? Because the doctors and the nurses, when they went into the hospital, um, weren't as comfortable treating phase one or EMG, DBT, goodness, diabetes one versus diabetes two. So again, you can't trust people, can't trust to get the care that you need. People look at you differently in terms of social stuff. And if you've ever been in a medical situation, uh, doctors often don't treat you like a person, right? They treat you like your disease or that you're an organism on a table and they're just treating you as the organism and not as the person. They can bring in students and not even tell you sometimes, and then you have like a bunch of kids in your room, not kids obviously, but younger people generally in your room, and they're talking about you as if you're not even there, right? So all of these things are pretty difficult for people to kind of appreciate when they're dealing with injury or illness. So when we go back to limitations, we still have those limitations, right? What does this mean, right? Well, now that I'm, having treatment with cancer, not me per se, but now that I'm having treatment for cancer, what does that mean? Like, sometimes when you say, okay, if I had cancer, terminal illness or something, I would be traveling every day. Okay, and you know, can you do that? Can you sit there and travel every day? Is that healthy? Would that be something that you could do? And then most people can't, right? Because they have to get their treatment, and their treatment precludes them being further away from their treatment team. So it's complicated, I guess, is the best word for it. So we have chronic pain, and then we have all the things that are layered on top of chronic pain, and then we have illness, and then all the things that are layered on illness. It's not just, hey, I have this disease or something like that. It's what this disease means to you, and that meaning, right, can stimulate past stuff. It can stimulate stuff from your history, from your childhood. If you developed ideas about who you are within the world that are now complicated by your new status as an ill or injured or person with chronic pain or something along those lines. So how do we start EMDR, right? Of course, we have to get our full history. And again, we want the full history, even if we are going to titrate this and shorten it or, start at a present trigger or future template versus starting as the touchstone, right? So we make clinical decisions with complex clients. And sometimes we don't do the touchstone all the way up piece, right? Sometimes with complex clients, we'll jump around a little bit, or depending on time, right? Sometimes with time, we might have to change how we do things here. So um, we start with getting a good history, and then what we do is we find the gaps, right? So are they ready to do EMDR? Not everybody is ready. So if you just found out that you have terminal cancer, um, are you ready to jump into therapy, right? Not necessarily, right? And that's where we go back to that idea of psychological first aid, right? So we want to make sure, okay, they just got this news. Let's make sure their needs are met. Do they have food, water, housing? Do they have people they can talk to? Do they have a good support structure, right? Before you even jump into trying to throw EMDR at somebody, we want to make sure that they are situated in a place where they can receive the work that you're doing, where their brain can move around, and it's not going to be stuck in this cycle of like OMG, right? So there's going to be some gaps there in readiness in the very beginning, and we got to work on that. We can appreciate that. And a lot of people, or at least, I had one person at least, I'm sure there's more, but it was sent to me. I deal with a lot of clients that are difficult for other people to deal with, and they're loud or whatever. It's funny because in EMDR, and I think I've mentioned this before, but in EMDR, we tell people in training, hey, you got to sit with people with emotion. Don't try to like just hand them tissues to show them that you're uncomfortable with their emotion. However, we are picky about the emotion that they're allowed to express. So when people come in and they're angry, right? Really, we kind of shut them down, like, oh, you got to calm down. You got to, but anger is an emotion. And if you just found out that you have terminal illness, and you had all these plans in life or these plans even the next week or month, right? And all of a sudden, like, no, you can't do any of that. You have to start your oncology whatever, your treatment episode, right? um that brings up a lot, that brings up lack of control, right? So we're talking about the themes now, which looks up a lack of control. It brings up possible defectiveness. There's something wrong with me, um the trust and safety, and like safety is huge. I'm in danger. I'm literally, have a terminal illness, so all of these layers of things are going to, for many people, cause them to react loudly, be angry, right? Again, we have our how we deal with death and dying and all that stuff, how we deal with loss, right? We go through stages, not always the same stages, right? But we can see some of that happen with people. And yes, they're going to go through these stages. They're going to get angry. They're going to be upset. In the middle of a session, that might come out. So if you're an EMDR therapist, I challenge you to be okay with anger, not just sadness, not just crying, but yelling, right? Some people yell. They're not necessarily yelling at you, but they're yelling, right? And that's uncomfortable. I appreciate it. However, we need to be able to figure out how to take that, because working with people that are dealing with the loss of their future is pretty significant. Okay. um so yell, let them yell. Give them the opportunity to yell. We give people the opportunity to cry. We tell them, it's okay. You spread your emotion, let it go. It's like a tunnel, you can go through it. Do the same thing with anger, please. Right, let people go through it. Has a beginning, a middle, and end. You can talk about, other ways to deal with anger, also, but we don't want to shut it down. Just like we can talk about other ways to deal with profound emotion, lots of crying and all of that. But again, we don't want to let them feel that it's not okay to express their emotion in the context of the EMDR relationship. So I've gotten those people, because they're behavioral flags now. Sorry, behavioral flags. Like, this person yelled at me and I was offended, right? So, um, that's who I ended up with a lot of times. Um, So let's go on a little bit, and that, you also have lifelong issues like lupus, and lupus people get, sometimes it's treated well, and they don't like have symptoms that cripple them on some level, and then you have people that can't leave the house, right? So you have different aspects of different things as well. You have ALS, right? And that's, terminal, but it's also what happens to you in between, because it's not just you that has to deal with some of these injuries and illnesses. It's your families. And you might, as a person dealing with a terminal illness, feel so bad that you're putting this on everybody else, right? This is something that your family and friends have to deal with, and you might blame yourself. right? That you're doing this to other people in some way, shape, or form, right? Not necessarily the case, not the case really at all. Or it's not something that you're doing. There's no intention there, but you can appreciate that. Yes, that there is an effect on other people, but it's not due to a fault of anybody. So we can look at families and not just on how this is affecting them, but now what do they have to do? Some families have to change their entire dynamic. Some people have to become caregivers. Some people have to become caregivers in doing activities of daily living that are uncomfortable and gross. That you wouldn't expect to do on a family member, or if you're the one that's injured or ill, have a family member do onto you, right? Luckily, there are some uh, nursing programs and stuff that you might get wrapped up in, depending on the injury or illness and the resources that you have. But at the same time, it becomes pretty difficult if you have to have that happen. Embarrassing is probably the best word. Um, And embarrassing happens with injury and illness all the time. I mentioned the diabetes thing, right? I mean, it's embarrassing to have to apologize to people after having um, that altered level of status. Not many people. There's probably a few. It can be like, shrug and be like, "Hey, that was just my illness. Sorry," and really believe it. Then you have the people that have to take care of you, right, and deal with all of that. Maybe they have to leave their jobs, or move back from wherever they were living, kind of stop their life. All of these things are things that people take on themselves as part of an injury or illness situation. So we do our history. We make sure they meet their normal history. We figure out what gaps they are for readiness, and then we start doing phase two. Get them ready. And phase two, I always say that we don't do well enough to really impress on people how much we want to involve the adaptive process here. So we want to spend as much time as necessary on phase two to have them, in your mind, have them most prepared to do the work, right? So I want them to have enough adaptive material that I am semi-confident that when they go into this, it won't just be doom and gloom, right? That it's front loaded. The positive adaptive material is front loaded. It's right there, and because we just picked it up and we just used it, and we can bring it up and refer to it. And if I did enough work pulling that stuff up, I also now have a huge bag or a huge box or whatever you want to say of antidotes, right? So when we talk about cognitive interweaves, we can use some of the material we get from phase two as interweaves, right? Because we're always saying that part of the problem with pathology is that these are memories, right? Stored with, et cetera, but stored in isolation. So they don't have access to all that stuff that you went through, even if you went through it. Even if you went through and did all the work to pull all this stuff up in phase two, the memory is stored in isolation. So when you bring up the memory, there's a wall there. They don't see any of that stuff. So if they get stuck on something and you notice that, hey, there was something that we talked about in phase two that would be an antidote to this, that's the opposite of what we're doing here. I can generate some curiosity here and say, huh, I just have a question for you. When you're saying this now, but also this, right? And so when they have also this, which is adaptive, positive, doesn't have access to it until you bring it into the session. Now it might break down the wall a little bit, and they might tumble forward and start moving down that track again, right? We use cognitive interweaves sparingly in order to help people move down the track, but they're antidotes, right? So use phase two, work on phase two, and this is sometimes the most challenging stuff they've ever had to deal with. So go ahead and work on it for a little while. Try to figure out what resources they need, not just doing a positive event timeline, figuring out when they've demonstrated positive qualities and ability to survive and bust through barriers throughout their life, but also stuff like them, resources, mastery resources, and other person resources talking about RDI, right? That might be able to help them through this whole process. Have you seen somebody go through something like this that was brave or courage or whatever that quality that you need or need more of? Have you seen somebody do this, right? And who is that? Would you bring that person, in your mind, and as a resource? What would it be like to feel like them, to express their behavior the way that they did? What would it be like for you to do that? And if they can imagine it, if they can feel it, if they can bring it into mind, right, then that quality is within them, and we can strengthen it a little bit, but that quality is within them. So that's what we want to do in phase two. Um, what memories are we going for first is going to be it's not always the same, right? We want to consider always chronological, because chronological, if we can do it, avoids blocking beliefs and feeder memories more than if we started somewhere else. It also has the best chance for generalization. And that's another thing with the map. I say get all the memories, because if you get all the memories, then you can choose where to go on the map. But because of generalization, you're not going to have to go everywhere. You're not going to have to do every memory. But we do want the map. We do want the context. So we do phase three. We get them. Well, we pick the memory that seems most appropriate. If it's going to be, it could be the time that they heard that they have the disease. But again, now if they have a disease like breast cancer or something like that, and somebody in their family, their mother, sister, aunt, etc., had breast cancer and died from it or something, that is another memory that's going to be coming up and feeding and triggering them. So again, you need the map. Go get those other memories. Um, so phase four, not much different in phase four. You just let it go, take a breath. What do you notice? And kind of just go with it. You have all the resources now that you can pull from as your box of antidote. If you need to use a cognitive interweave, you can use some of that. Again, we also use the where they're stuck and move them forward based on where they are in the moment when they get stuck with cognitive interweaves. The box of antidote is just another resource. And then as far as moving forward in terms of present triggers and future templates, there's going to be ongoing present triggers. So sometimes, hope the people that we're working with in this case are going to have more and more issues over time. So they might have to come back for some plus ups, but we should do pretty good in terms of getting to the point where they are not so distressed. They're not blaming themselves. They're not beating themselves up. And they're able to cope with the things that are coming up. You got present triggers and future templates. They're able to cope with things as you go forward. But I would keep my door open, because some people might come in and like, hey, they want to do this now, or this happens because some family member got fed up and couldn't take it anymore, right? Which happens. This is, I'm just putting this stuff out there, but this happens. So we had, for a lot of us that went to EMDR Institute or EMDR HAP training, there's that older video with Mary, the cancer, the person that's suffering from cancer. And one of the things that were coming up with that was, that the person's husband wanted to leave, right? Because he couldn't take it. And so that was part of the trauma they're dealing with. So again, it's not unheard of for these issues to come up. All right. So I'm hoping this has been helpful, just to kind of explore some of the chronic pain, the issues, the memories, where they come from, how this is an ongoing issue for people that have chronic or um, terminal illnesses or injuries or illnesses that are not expected to get better. Or much better for that matter, how it affects the roles, the things that they can do, the participation and things that they used to enjoy, even working or being with other people. They can't go and do the same thing that they used to do with the same peer groups. All of these things complicate the clinical picture and are all avenues for us to explore, find some memory targets, and work on them with the client. So let me go ahead and take a step back. I see we got couple people still on today. Does anybody have any questions, thoughts, issues, alibis, anything that you think would be helpful in terms of chronic pain right now? No questions that I can see anyway. What about you? Do you have a question? All right. I'm going to send out a little survey so that people can go ahead and ask the questions that they want me to answer on here. Um, and that might be a good way to do it, right? It's just trying to get some idea of what people are looking for. Again, this section, I'm trying to do something different, where it'll be the section will be pre-recorded, and then I'll be in here. Then we'll go through the segment, right, of this work here, and then we'll go into questions, right? And I'll be here through the whole process, so it's not going to be like it's not live, but it is live. I'm just showing a segment while we're live. Okay, and that just helps me organize things a little bit better. And I want to be as like in person and stuff as possible, so I can get you the information in a way that you can receive it. But I also want it to be something engaging and fun-ish, so that you want to watch it. So hopefully that'll work out. Thank you for coming. And tomorrow, let me just kind of see what we got going tomorrow. Tomorrow's Thursday. So let me just see what we got going tomorrow. Um, that was that week. This week. All right. So tomorrow, we're going to be talking about some body dysmorphia stuff. So that'll be fun. And yeah, we'll kind of go into some of that as well as, we get into it as much as possible and some of the other aspects of, how we see ourselves. Um, And again, if anybody has any questions or comments, feel free and reach out. This is Doc V from EMDR News, and I look forward to seeing you tomorrow. Bye, everybody.